Hi students, hope you're all doing good. In this video, we are going to discuss about ectopic pregnancy. First, let us know what is ectopic pregnancy. In a normal pregnancy, we know the blastocyst is going to implant in the endometrium, right? But ectopic pregnancy is a pregnancy where the blastocyst is going to implant itself anywhere outside the uterine cavity or the endometrium. Okay, so the word ectopic itself means an abnormal position or a location. Okay, so that is why it is called as a ectopic pregnancy. That means a pregnancy at an abnormal location. Okay, now see. So in a normal pregnancy, blastocyst implants itself in the endometrial cavity. But in an ectopic pregnancy, so implantation happens outside the endometrial cavity. Okay. So remember that ectopic, the term itself means abnormal location. Okay. Now, what are the sites where the ectopic can get implanted? Okay. So sites of ectopic pregnancy. So these can be anywhere outside the uterus. Okay, so it can be in the adnexa itself. Okay, so repeat. So these sites can be anywhere outside the endometrial cavity. Okay, for example, it can be in the adnexa, that is, it can be in the tubes or in the ovaries, or it can be in the cervix, or it can be in the cesarean section scar. Okay, if she had a previous history of cesarean section, or any scar. Okay, but cesarean section scar pregnancy is common what we see, and it can also be an abdominal pregnancy. Yes, and remember there can also be heterotopic pregnancy. What is heterotopic pregnancy? A pregnancy in which both the normal and an ectopic pregnancies are seen. Clear? So we'll come up again. So sites of ectopic pregnancy, number 1. It can be in the adnexa, so it can be a tubal ectopic, or it can be a ovarian ectopic. Okay, then it can be a cervical ectopic or abdominal ectopic. Then it can be a cesarean section scar ectopic. So cesarean scar ectopic or a heterotopic pregnancy. Clear? Among this, if you ask me, ma'am, which is the most common site among this? Okay, so remember that it is the tubal ectopic which is the most common site. Okay, first let us make clear about the tubal ectopic sites also, because we know in the tube we have, these are the parts of the tube, right? If you take the parts of the tube and suppose this is the uterus that is coming here. So what are the parts? We have the interstitium. Okay, let us consider this as the isthmus, ampulla. Okay, then infundibulum. These are the fimbriae, right? So among this, which is the most common site of ectopic pregnancy means the place goes to ampulla. Clear? So ampulla takes the first place because in the ampulla you have more plicae. Okay, so that favors implantation of the blastocyst in the ampulla itself. Okay, so followed by ampulla, it is the isthmus, right, and then it can be the infundibulum and it can be the interstitium. Clear? So these are the various sites of ectopic in tubes. Okay. Now, apart from tubes, which is the next most common site, means it is the ovaries. Okay. So ovarian ectopic is the second most common site. Okay. And the least type of ectopics include cesarean-scar ectopic. Okay. Cesarean-scar ectopic, cervical ectopic, and the abdominal ectopic. Okay. So these are the least common site of ectopic. Clear? Now we'll see what are the risk factors for getting an ectopic pregnancy. See, a person will have a highest risk of ectopic pregnancy when she already has a previous history of ectopic. Okay, and that constitutes the highest risk. Okay, keep that in mind. So, highest risk is seen with the previous history of ectopic pregnancy. Okay. And the second highest risk is when she has undergone any surgeries in the tubes. Okay, it can be a surgery for the prior tubal ectopic pregnancy, or when she has undergone a tubal sterilization or a recanalization procedure also. Okay. So, second highest risk is surgeries in the tubes. That can include surgeries for previous ectopic or tubal sterilization procedure or tubal reconstructive surgery. Okay. Next highest risk is with the pelvic inflammatory disease, especially when there is a history of salpingitis. Okay. So, history of pelvic inflammatory disease, especially when there is a history of salpingitis. And why I am stressing this is the most common cause. Okay, so the most common cause that can lead to ectopic pregnancy. Clear? So, the highest risk is seen with the previous history of ectopic pregnancy. Okay, whereas the most common cause of ectopic pregnancy that we see clinically is pelvic inflammatory disease. Okay, and next is endometriosis, because endometriosis can distort the tubal anatomy. Okay, endometriosis distort the tubal anatomy. And next thing is when she has a history of infertility and she has undergone any of the artificial reproductive techniques. Okay, so infertility and associated ART reproductive methods. Okay. So, see, let us see why this is important. Okay, because in infertility, if she has already damaged tubes or any abnormal, so let us see why this is important. Because in infertility, already she could have had an abnormality of the tubes. Okay, that could have been the cause of infertility, and during infertility management, she would have been put upon a lot of fertility drugs, namely clomiphene citrate or letrozole or gonadotropins, and these fertility drugs are going to cause immotility of the tubes. Can you understand? Okay, immotility, or it can at least affect the normal motility of the tubes. Clear? So, there are two reasons for this. Number one, One is, yes, associated abnormality of the tubes already present. Okay. And there is an association between the fertility drugs and ectopic. Okay. The drug can be anything, like it can be a clomiphene citrate, right? Or it can be a letrozole or gonadotropins. Okay. What they are going to cause? They are going to cause impaired motility of the tubes. Clear? And the next risk is seen with smoking. Okay. Smoking can also affect the motility of the tubes. Okay. Affects the motility of the tubes. Next one is contraceptive failure. See, you can ask me, ma'am, contraception prevents pregnancy. Then how come ectopic pregnancy will happen? See, actually contraception prevents any pregnancy. But remember, if there is a chance of contraceptive failure, okay, then there is going to be an ectopic pregnancy. Okay, so that point you have to make it clear. So it is contraceptive failure, not the contraception as it is. Okay, and usually what will be giving for contraception? We'll be giving oral contraceptive pills or progesterone only pills or even IUCDs, right? So these are the commonly used things, right? So whatever it is, okay, say it is a combined oral contraceptive pills, okay, combined oral contraceptives or progesterone only pills or IUCDs, okay. So in all these things we have one thing common. Yes. So we have a progesterone component. You accept that? Yes. So there is a progesterone component in combined oral contraceptive pills. Yes. Progesterone, definitely in progesterone only pills. And IUCDs, especially in the Mirena, there is a progesterone component. Right? So what does progesterone actually do? Progesterone is going to reduce the motility of the tubes. Clear? So what is going to happen? When fertilization is happening in the tubes, especially, it happens in the ampulla of the tube again, right? So this point can also be added. Why? The ampulla is the most common site of ectopic pregnancy, because the fertilization as such it is going to happen in the ampulla itself. Okay, so when the fertilization is happening in the ampulla, the fertilized embryo has to travel for implantation, and it travels mostly by the motility of the tube. Suppose if the motility of the tubes is not happening properly, then what happens? There is a high chance that the blastocyst get implanted there itself. Okay, so the motility is affected. And another one is, suppose if you take other IUCDs like copper IUCDs, okay, what is going to happen is there is blockage of the tubes as well. Can you understand? So if you see, so let us take, this is the uterus, right? So I am giving a copper T now. So I will be implanting it like this only, right? So the copper T is going to take this position. So what is ultimately happening? There is blockage of the tubes, right? See, there is blockage of the tubes. Suppose if a fertilization is happening here, okay, and this has to travel here, so this blockage doesn't permit the further growth of, it doesn't permit the further movement of the blastocyst or embryo, whatever it is. So what happens? There is a high chance that it gets implanted in the tubes itself. Can you get it? Yes. We can see some other causes also. We can include cervicitis, multiple sexual partners, and lower socioeconomic status. Okay. So you can ask me, ma'am, in what way these are going to cause the ectopic pregnancy? So far, I have explained everything. So there is an effect in the motility of the tubes, or there is going to be any injury to the tubes. Likewise, we have seen. Now, in what way this is going to cause ectopic pregnancy means, remember, all these are common cause for pelvic inflammatory disease. That is PID. So, indirectly, PID can lead to ectopic pregnancy. Yes, so indirectly these factors can also lead to ectopic pregnancy. Clear? Now, we'll see some important clinical manifestations in ectopic pregnancy. Okay? In fact, we can take these clinical manifestations as a triad of ectopic pregnancy. Okay? So, the triad includes number 1, amenorrhea. Okay? Number 2, there can be severe abdominal pain. Number 3, there can be bleeding. Okay, come up again. What are the clinical manifestations in ectopic pregnancy? It is amenorrhea, severe abdominal pain, and bleeding. Okay, so whenever you get a clinical scenario, okay, for ectopic pregnancy, definitely they will be mentioning this criteria. Clear? Now, we'll see what is the fate of ectopic. Okay. So, fate of ectopic pregnancy, when imagine, since the tube is the most common site of ectopic pregnancy, we will imagine a tubal ectopic itself. Okay. See. Okay. Let's imagine a tubal ectopic itself. And if ectopic pregnancy has formed anywhere here, ectopic, okay, say a tubal ectopic can go either for a spontaneous abortion, that is tubal abortion, or it can go for rupture. Clear? And this abortion can happen in the ampulla. Okay, so this is the ampulla, interstitium, isthmus, infundibulum. Okay, so remember, in the ampulla, the chance of tubal abortion is high. Okay, and whenever it is going for rupture, the ectopic which has formed in the isthmus, okay, has a highest chance of rupture. Okay, whereas an ectopic which has formed in the interstitium has a longer duration of stay. Why? Because imagine an ectopic is formed here. This is going to take support from this myometrium also. Yes. So, this is going to stay for a longer time. It can stay even up to 16 weeks of gestational age. Clear? Okay. So, why I wanted to tell is, we are going to discuss some of the features of a ruptured ectopic also. Okay. When an ectopic goes for rupture, there occurs hemoperitoneum. Okay, so the blood is going to come out, and that is going to lead to hemoperitoneum. Okay, so this hemoperitoneum can irritate the diaphragm, right, and it can cause pain in the shoulder. Okay, irritates the diaphragm and it can cause pain in the shoulder. So, this can be called as shoulder tip sign. Okay, and we also know the blood can collect itself in the cul-de-sac also, right? So, blood collected in the cul-de-sac also. Okay, so what can happen? That can cause pressure on the rectum. Okay, so it can cause pressure on the rectum. When it causes pressure on the rectum, there can be an urge to defecate. Okay, so there is an urge to defecate. Okay, suppose there is a huge amount of blood loss that has happened. Suppose there is a huge amount of blood loss that has happened due to the ruptured ectopic. Okay, what it will be leading to? It can also lead to hypovolemia. Okay, and signs of hypovolemia can also be present in a patient. Okay, so that can include syncope or vertigo. Okay, so finally, increased amount of blood loss can result in hypovolemia, and that can result in symptoms like syncope or vertigo. Clear? Now we'll see what are the examination findings we can have. Okay, so on examination, okay, see usually on perabdomen examination, what you will be able to see is tenderness of the abdomen. Okay, so this tenderness of the abdomen can be present in the lower abdomen usually, but suppose if the rupture has occurred earlier, okay, so it has ruptured already, then there can be a generalized tenderness also. Okay, and sometimes it can also lead to peritonitis, right? So signs of peritonitis like guarding and rigidity can also be seen. Okay, next is for vaginal examination. On pervaginal examination, you can see the uterus size is enlarged. Okay, and most of the times size of the uterus will be less than the period of gestation. Clear? And also remember, there will be cervical motion tenderness. Okay, and sometimes, okay, sometimes you can also feel the adnexal mass. Okay, and adnexal tenderness can also be present in some cases. Clear? And sometimes while you do a local examination of the bleeding, okay, decidual casts can be seen. Okay, so this is an example of a decidual cast passed in a case of ectopic pregnancy. Clear? Now I want to make clear about the vitals also. Vitals in moderate bleeding usually will not have much change. Okay, so usually no change. Sometimes there can be a slight increase in BP, and because of the vasovagal response, there can be bradycardia or hypotension. Okay, but what will be happening in case of severe bleeding? It is just the opposite, right? So there can be hypotension and tachycardia. Clear? So in case of severe bleeding, there can be hypotension and tachycardia. Okay, Now we'll see some lab findings also in general. Okay. So when you come to lab diagnosis, if there is a rupture, then hemoglobin hematocrit usually falls, right? Hemoglobin and hematocrit falls. Okay. There can be leukocytosis. Okay. And most important lab diagnosis is we have to confirm it is a case of ectopic pregnancy. So when we do a UPT or a serum beta hCG, they are going to be positive. Okay. And the lower limits of detection in a case of urine test is, okay, in a urine test, the lower limits of detection for beta hCG values is 20 to 25 milli international units per milliliter. Okay. Whereas in case of serum beta hCG, they can diagnose even less than 5 milli international units per milliliter. Okay. So serum beta hCG is always preferred when you are suspecting an ectopic. And remember, with serum beta hCG, okay, we can also rule out if there is a doubt in whether it is a ectopic pregnancy or a normal intrauterine pregnancy. Okay, what you can do is, you can repeat the serum beta hCG after 48 hours, because this 48 hours is the doubling time of beta hCG, right? So this is the doubling time. Okay, so there can be three possibilities. One, it can rise normally. Okay, otherwise there can be a rise but not normally. Okay, not to the normal levels. Okay, and the second scenario can be, there can be a rise in beta hCG but that is not at a normal range. Okay, so rise but not at a normal range. Okay, and the third choice can be the beta hCG can be decreasing. Okay, so how we are going to make a diagnosis of this? See, obviously when it is rising normally, that is going to be a intrauterine pregnancy. Okay, and remember, the doubling should increase at least more than 30 to 35% of the previous value. Clear? And if it is rising and it is not at a normal range, then there is a pregnancy, but yes, it is not in the normal site. So that means there is a ectopic pregnancy. Okay, suppose the value is decreasing means, yes, then it is a failed pregnancy wherever it is. Okay, so that is a failed pregnancy. Clear? Okay. Now another important investigation we'll be doing is ultrasound. Okay, in ultrasound, most of the times we'll be preferring transvaginal ultrasonogram more than transabdominal ultrasonogram. Okay, and remember, in transvaginal ultrasonogram, the discriminatory level, okay, that is, we can say discriminatory threshold, okay, for making the diagnosis, okay, of a pregnancy. That is, discriminatory threshold is the value of beta hCG at which the pregnancy can be visible in the TVS as well as in TAS. Okay, so if you take for TAS, the discriminatory threshold is, suppose if the value of beta hCG is 1500 milli international units per milliliter, then you can tell 80% of the intrauterine pregnancy can be diagnosed. Okay, suppose if the value is around 2000 milli international units per milliliter, then you can say 90% of the intrauterine pregnancy can be diagnosed. Okay, and suppose if the value is around or more than 3500 milli international units per milliliter, then 99% of the intrauterine pregnancy can be diagnosed. Okay, so this is recommended now. And in transabdominal ultrasound, the discriminatory value is 6000 milli international units per ml of beta hCG. Clear? Okay. Okay, we'll see the ultrasound findings now. Okay. Okay. First, we'll be checking for the uterus. Right? So, in the uterus, suppose if there is an empty uterine cavity or there is no evidence of intrauterine pregnancy means, then you have to search for some ectopic location. Okay. So, there is an empty uterine cavity. Okay. That means no evidence of intrauterine pregnancy. Okay, but there is always an exception, right, to any rule. So, it is a heterotopic pregnancy in which you can see both intrauterine pregnancy and extrauterine pregnancy. Okay, so this is a ultrasound picture of an heterotopic pregnancy. See, this is an intrauterine pregnancy. See, this is the uterus. Okay, can you see? So, this area is the uterus. This is the cervix. Okay, are you able to see? Okay, so in that you have the uterine cavity here. Okay, and this is the intrauterine gestation. Okay, whereas this is an ectopic gestation. Okay, somewhere here. Okay, another gestational sac with embryo seen. So, that is an ectopic gestation. So, when you see both intrauterine pregnancy and ectopic gestation together, it is a heterotopic pregnancy. Clear? And so, what you have to do is, and also you can have a pseudo-gestational sac or a decidual cast. Okay, so sometimes a pseudo-gestational sac or decidual cast can be seen, and this can be seen in 10 to 20% of the cases. Okay, and another finding is sometimes there can be thick echogenic endometrium also. Okay, so after checking all the findings of the uterus, remember to check the adnexa also. So, when we check for the adnexa, number 1, okay, if you have a simple adnexal cyst, okay, nothing you see only a simple adnexal cyst. Okay, so in that case also remember there can be a 10% chance that it can be an ectopic. Okay, and suppose if you see a complex extra adnexal cyst or mass, then there is 95% chance that it can be an ectopic. Okay, suppose if we take this cyst to be a intra-adnexal cyst or intra-adnexal mass, then the chance can be more that it can be a corpus luteum. Have I made it clear? Yes. And next one is, you have a sign called Tubal ring sign or the blob sign or the bagel sign. Okay, so it is called as Tubal ring sign or blob sign or bagel sign. What happens is there is an echogenic ring. Okay, so can you see this? There is an echogenic ring that will be surrounding the ectopic, and this is seen mostly in the case of unruptured ectopic, correct? Okay, so echogenic ring seen surrounding the unruptured ectopic. Okay, and when you go for color Doppler, I hope this is one of the favorite sign, right? So, this is what? Yes, it is ring of fire appearance. And where else you can see this? It can be seen in a case of corpus luteum also. Okay, also seen in corpus luteum. So, why this ring of fire appearance happens? Because there is increased vascularity. Okay, there is increased vascularity. Okay, so when you put a Doppler around that, so this increased vascularity is seen like a ring, right? So this is taken as a ring of fire appearance. Okay, and one of the most important thing I have to tell is, when you have a live extrauterine pregnancy, okay, that means if you have a live extrauterine cardiac activity anywhere, then it is 100% specific for ectopic pregnancy. Have I made it clear? Yes. When you have a live extrauterine, when you have a live extrauterine pregnancy or a live extrauterine, So, when you have a live extrauterine pregnancy, that is cardiac activity seen anywhere outside the uterus, then it is 100% specific for ectopic pregnancy. Clear? Extrauterine cardiac activity. Okay, so this is 100% specific. Clear? Okay. Now remember, in the peritoneal cavity, there can be free fluid or hemoperitoneum, right? So, there can be free fluid or hemoperitoneum, where it can be present in the cul-de-sac or pouch of Douglas. Okay, and when you see hemoperitoneum or free fluid in the pouch of Douglas, it can be 70% specific and 63% sensitive for ectopic pregnancy. Clear? And sometimes this free fluid, and sometimes the free fluid can be seen in the Morrison's pouch also. That means the rupture has occurred and there is a huge amount of blood and the collection of blood has gone until the Morrison's pouch. That means definitely in that case you have to go for a surgical management. Clear? Okay. Okay, so these are the ultrasound findings. Now, previously they were doing culdocentesis. Okay, so in culdocentesis what they will be doing is, so this is a procedure. They will be using a needle, say some 18-gauge needle, okay, and they will be inserting the needle in the pouch of Douglas. This is the pouch of Douglas, right? And they will be aspirating the blood or the free fluid, whatever it has collected in the pouch of Douglas. Okay, so what they will be assuming is, if you get a non-clotting blood, okay, that means it has happened due to a ruptured ectopic. Okay, so this was previously used when ultrasonogram was not available, and this is not commonly done now. Not commonly done now. Okay, and in diagnosis, I want to talk about one of the very important diagnosis, that is diagnostic laparoscopy. Okay, so when you go for a diagnostic laparoscopy, what are the indications? Indications include, suppose when ultrasound examination is unable to differentiate between the ectopic pregnancy or a cyst, okay, between the ectopic pregnancy or say a bleeding ovarian cyst. Okay, and when there is a significant collection of intra-abdominal fluid. significant collection of intra-abdominal fluid also. Okay, and the advantage of using diagnostic laparoscopy is it serves not only as a diagnostic method, and if needed you can also convert it into a therapeutic method. Okay, so it is not only diagnostic, okay, can be therapeutic also. Clear? So this is a picture of a diagnostic laparoscopy. Okay, where you are able to see the uterus. See, this is the uterus, okay, and this is the tube, okay, tube, right, and you are able to see a pregnancy outside here. Okay, so this is a ectopic pregnancy that is seen in diagnostic laparoscopy. Okay, and previously some other investigations were also done. Okay, we'll just have a look into that. Okay, they were also doing serum progesterone levels. Okay, and if the value of progesterone is more than 25 nanogram per milliliter, then that means it is a normal intrauterine pregnancy, and the value is less than 5 nanogram per milliliter, then it is non-viable or an ectopic pregnancy. Okay, anyhow we are not doing this now. And same way, previously uterine curettage was done directly. Okay, so why they were doing this? To diagnose villi in the cavity. Now, so far we have been discussing about what is ectopic pregnancy, what are the sites of ectopic pregnancy and the diagnostic methods. Okay, I also want you to know the types of ectopic pregnancy. That is, an ectopic pregnancy can be an acute ectopic pregnancy, or sometimes it can also present as chronic ectopic pregnancy. Okay. See, what is happening in acute ectopic pregnancy means there is a trophoblast proliferation that is happening at a higher rate. Okay, so there is a increased amount of serum beta hCG values. What is happening in chronic ectopic pregnancy means there are abnormal trophoblasts. Okay, so these abnormal trophoblasts are going to die early. So either there can be a static serum beta hCG values, or there can be a decline in serum beta hCG values at a much higher rate. Okay, so number 1, trophoblast proliferation occurs rapidly. In chronic ectopic pregnancy, trophoblast proliferation is slow, or there is abnormal trophoblasts which die early. Okay, and what will happen to your serum beta hCG value? Serum beta hCG levels are high. Okay, whereas here serum beta hCG values are stagnant or static, or it can decline at a rapid rate. Okay, and also remember, most of the times we see ectopic pregnancy in the acute stage. Okay, so acute is more common. Okay, whereas a chronic ectopic pregnancy case is less common. Clear? And whenever there is an acute ectopic pregnancy, most of the times we go for a surgery. Okay, for diagnosis. Okay, we have seen diagnostic laparoscopy, or when there is a rupture. Okay, and it has led to, yes, it has led to hemorrhage and hypovolemia. Okay, usually in chronic ectopic pregnancy, what happens means there will be formation of a complex pelvic mass. Okay, so for this, surgery may be indicated. Clear? Now I want you to make clear that whenever a patient presents with the ectopic pregnancy, that is when she has amenorrhea, bleeding, or severe abdominal pain, Okay. First, we have to resuscitate the patient. Okay. That is the first priority, right? Then we go for a per-abdomen examination. And in per-abdomen examination, see if you are getting any localizing signs or not. Okay. Suppose if you don't have any localizing signs, okay, then you can go for fast ultrasonogram. Okay. Fast means focused assessment with the sonography in trauma. Clear? Suppose if you have localizing signs, then you have to check for the vitals. Okay. Suppose if the vitals are good, then you can suggest them to undergo laparoscopy. Okay. Suppose if the vitals are not stable, then you can take them directly for laparotomy. Okay. So, I hope in this video you would have understood what is ectopic pregnancy, what are the various sites of ectopic pregnancy, in that which is the most common site, and in the tubes which are the most common site, which are the least common site of ectopic pregnancy, what is acute ectopic, what is chronic ectopic, and we also have seen what are the investigations to be done in a case of ectopic pregnancy. Okay. Now with this part we will complete this. In the next video of ectopic pregnancy we will be discussing the types of ectopic pregnancy and management in detail. Until then, take care. Bye bye.